Moving to the panel discussion, and I would like to invite Dr. T.P. Sahoo, who is the moderator for the panel. Dr.
Yeah, can I share my slides?
Yes, sir.
Yeah, I have all the panelists there. Can someone tell me? Everyone is there?
Sir, Dr. Shekhar Patil, he is not reachable, sir. Rest all
Shekhar
at
Patil sir is not there?
No, sir.
Okay.
Rest all at
So we have Dr. Shitish, Dr. Kaushal, Dr. Samir and Bharat. We have all the four, no?
Right.
Yes, sir.
Yeah. Just if Shekhar Patil sir joins in, just let me know. Okay. Thank you. Okay. So my screen is visible and I'm audible. Can someone confirm that?
Yes, sir.
Yes, sir. Yes,
Yeah.
sir.
Yes, sir. Audible.
Yeah, so we jump to the panel because we're already 10 to 15 minutes late, delayed as per the schedule. So we had five abstracts, 5 lectures based on the post-ALK treatment. What do we do? And this is a field we need to engage ourselves because this is the area where a lot more patients are going to come, as we and all of us know that once we get a particular ALK therapy in, they will definitely fail, and all the ALK inhibitors are going to develop resistance, and gradually we need to plan our action, how we need to plan the treatment post-ALK. So I take a case, and this case actually is a true case published in New England Journal of Medicine. So nothing arbitrary about this case. This is a published case actually. So it's a 55 years old female, non-smoker, diagnosed as stage 4 non-small cell lung cancer, adenocarcinoma, ALK positive, treated with first-line crizotinib. Progressed after 13 months with systemic progression of disease. There were nothing oligomets or no brain alone. It's a systemic frank progression. So before I go on, I'll take the first question to Bharat. I'll take what Samir told. Is it that just because of the convenience of the tissue, we all do the PDL1 and go for NGS? Or do we do the sequential one after one? Because that is only we do it for the coupon-based patients. If there is an affordable patient, Bharat, is it not that we do the routine broad panel NGS? At least the things which will cover all the targets which are there, and we do the PDL1 by IHC. Is it how we proceed normally?
At least for the last 6 months to 1 year, my practice has changed to this. That is, do the PDL1 and if possible an NGS, or if not possible PDL1 and then the ALK and ROS IHC, EGFR, BAMS, PCR and MET and BRAF. But I think over the last 6 months, it is PDL1 and NGS because that seems to be more logical nowadays.
Okay. So now, both are right. Just to tell that part of the question, will come to post-progression. Should we be doing NGS? Is the second part we'll answer in the panel. But this part, Samir, I think that is the answer that all of us do prefer NGS now. And if you do a PDL1 and then do NGS, is fair enough. We want to do it one time, get all the tests done, rather than do it sequential. But someone wants to do the in-house is there. You can do the in-house EGFR quickly, get that report and probably get the most bulkier of the targets. The 20 to 20% of a patient have EGFR mutation. But I think that's how most of us do now. If finance is not a constraint, and 99% of our practice is based out of a third-party lab. So we always send samples to outside, most of us. So now, coming to Dr. Kaushal. This is a patient who had progressed and on progress with crizotinib first line ALK positive, nothing as a double mutation, it's a single ALK mutation. And how do we proceed? What is your practice today? How do you want to proceed with this case?
Yeah, sir, in this patient, as the patient progress after approximately 1 year after the crizotinib, so I would like to do a rebiopsy and retesting for molecular markers.
Okay.
To know regarding the same ALK positivity as well as development of any other mutations. So I would like to do rebiopsy as well as
So
NGS.
basically you would prefer a rebiopsy. Samir, is it that how you practice and how difficult or how easy it to get a patient convinced for rebiopsy, and also the enough tissue? Do you get enough tissues, and what percent of patients of your biopsy on rebiopsy fail actually?
Yeah, definitely tissue becomes an issue. We have already been discussing this thing. So at times it is very difficult. The site is difficult to access, or at times the patient fails in the brain only. So the difficulty is there regarding that issue. So at this time we can go in for liquid biopsy also.
You don't sound very convinced. You don't sound very convinced of liquid biopsy.
Exactly.
There was a hesitation when you told that part. So is it that tissue is still your preference?
Yes, always it is
Yeah.
a preference. And liquid biopsy, I am not actually very convinced that it is. If nothing can be done, then definitely I will like to get it done. But if
Shitish,
tissue is available, then definitely tissue.
Shitish, it's a very important point. Samir and both Kaushal are very clear that tissue is the gold standard. All of us agree. What do you feel? Which is more convenient? And if there's a liquid biopsy available to you with the newer technology and the fallacies of the older liquid biopsy limitations are now going away, are you convinced now liquid biopsy is good enough? If there is a negative in liquid biopsy, you would then go for a tissue biopsy. Can we go this way around, Shitish?
Practically speaking, sir, so I agree with the panelists that the tissue is always preferred first. But practically speaking, we are doing more liquid biopsy in progression than a tissue biopsy nowadays, because the patient might not be ready, the difficulty in obtaining samples, and almost we found that the quality of the biopsy that we are getting in the liquid also, it is also quite significantly concordance. And what I
Okay.
remember reading one article where they show that the liquid biopsy nowadays with a modern technique and the mutation that we will found after ALK progressions are almost equivalent to what we get from a tissue. So why not with a less invasive form? Still,
Okay.
that is what
Okay.
we prefer.
Dr. Bharat, your last word from you on this point, because it's very clear now. The point is coming is if tissue can be got, if you can get a tissue easily, do access it. That's the most important part, how we do it. But liquid biopsy can play a very good complementary role. They are not fighting for each other's space, but actually they can help each other out. And if you are negative on one, it won't harm you to do the other one so that you don't miss out on whatever targets you can find.
Dr. Vanita had an excellent presentation just an hour back regarding the Canadian registry. And I think within a short period of 1 to 2 years, we would be moving towards liquid biopsy preferentially. The technology is improving, and on NGS, the liquid biopsy seems to be picking up more from the ctDNA, because when we are biopsying, however big the radiologist says that he has taken the tissue, there is necrosis, there is other tissue, there is stroma, everything. I feel that in 1 year to 2 years, it will be more and more liquid biopsies, and that's the way I think they're moving towards.
So the take home for this slide would be that NGS is the way all of us want to proceed. Point number one. Point number two is liquid and tissue both are complementary to each other. At this point, probably tissue biopsy is predominant, but how I take it, that if you are negative on the tissue, you would not harm you. It would be okay to do a liquid, because they sometimes you find more tests on the liquid. But still now, whatever the data is there, you have more. I'll show you one of the lorlatinib data, which is showing that the mutations on a tissue actually is much more significant than on a liquid. But as the technology is evolving, that's what it is. There are some limitations. Just very quickly, you won't get a gene amplification detection probably on liquid. That's a very rare way how you can get a crizotinib resistance. So you would also like to get a complementary thing. I think if you can get a tissue, nothing like it. And if the cost is okay, some people do send both tissue and liquid nowadays. That also I've seen some of the practitioners doing that, and few of the companies also are doing complementary. The second one, if you pay for the first one. So basically, all of us want NGS. Is it fair, Dr. Kaushal? That's what it is all about now?
Yeah.
Okay. So moving on, I'll just skip this part. I'll just want you to take this question, Kaushal, and then Shitish. Which type of NGS? Do you write something, or it just writes that? Because the lot of things are on targeted amplicon-based NGS. Let's say you have a tissue report or NGS report, then that shows that it was a targeted amplicon-based NGS panel. How would you read this, interpret this report? And what are the limitations do you feel with this part of the NGS panel if it is a targeted amplicon-based NGS panel? Any idea?
So frankly speaking, I have not much idea regarding this, but
No
I
issues.
routinely prescribe NGS for
Okay.
lung biomarkers like that.
Okay. So I think we need to also read into NGS little more. Shitish or Bharat, anyone wants to take this? Because this is something, what NGS we are sending, what people are doing, and we need to also know how to interpret the reports. Anyone in the panel?
To my knowledge, I may be wrong. I'm not much well read about this, but a targeted amplicon-based panel looks at specific mutations that you are looking, but it looks very deep into those mutations. So if you're looking for lung cancer and lung cancer specific ALK or other mutations, it would cover more than 99% of the mutations there, but it may miss out on some other things.
Yeah,
So,
basically you're actually right, Bharat. The point, yeah, please complete.
It looked deeply into what we are looking, but it's a little bit more focused rather than very broad-based.
There were slides shown in the last few lectures that if you look at the second generation TKIs like the alectinib and the others, you would see more of the escape mechanisms like the MET thing coming in, the BRAF, the others coming in. So if you want to look into this, probably a targeted based amplicon NGS does not, because it only looks into the ALK thing. It does not look into the other mutations that could have coexisted with it. So basically that's what you're looking. You're looking at a very specific thing. So for our interest, I think we should be looking at a broad panel. We should look beyond the ALK domain, which also should look beyond the others thing, because around 35 to 40% of the mutations in the second generation TKI for ALK inhibitors have actually mutations beyond the ALK domain. So that is something all of us need to know when we are looking at the NGS panel. Kshitish, anything to add on this?
No. I agree, because actually, frankly speaking, as per Dr. Kaushal has said, we do not look for the NGS panel. We just try to send it to the standard lab, which do a broad panel. But I agree with you that there are a lot of other mutations are also there. So we should look for a broad panel.
Okay. So now moving on to the next part of the things. So this patient, we just want to skip this part of it and just go into that. So tissue biopsy was done, which was sent for NGS, and the ALK C1156Y mutation was there, which is a crizotinib resistant. So Dr. Sameer, what would be your treatment of choice for this patient who on crizotinib post 1 year has developed C1156Y mutation, which is a crizotinib resistant mutation? How would you proceed with this patient?
So if the patient can afford lorlatinib, maybe try. So, or if lorlatinib is not available, maybe electronic. I'm not very sure electronic.
Okay, no, sure. Kshitish, what would be your treatment of choice in this case? Or Bharat, maybe?
I do think so that this is a lorlatinib sensitive mutation, but I'll have to check. I will have to check that. I'm not sure, but I think it is, and I would prefer to go with lorlatinib.
Okay,
if it's a sensitive mutation.
Yeah, please.
But I'm not sure.
Kshitish?
Yeah. So I agree with Dr. Bharat. So there is a lot of new mutations are coming. There are few mutations that I remember they are very specifically sensitive to lorlatinib.
Okay. My point was, is it that the lorlatinib is post failure of the second generation TKI first line, and if you use the crizotinib, till now the data is for second generation and then lorlatinib. Has it changed over the last few months, or that lorlatinib could be given directly post crizotinib? There's nothing wrong; it will still be active. But is it that if you give a second generation TKI first line and then lorlatinib comes in as the second line, and then if you are given a crizotinib, probably ceritinib, alectinib, and then a lorlatinib? The frontline data is ongoing. Kaushal, what is your practice? Because I practice the way that if it's crizotinib, go for a second generation TKI. Maybe for my choice, I go for ceritinib if I'm not given it first line, because crizotinib comes free of cost to me, and then I go for a lorlatinib. Kaushal, how do you practice?
Yes, sir, I agree with you. I am going on the same way. Crizotinib followed by the alectinib or ceritinib followed by the lorlatinib.
Okay. And if you are given a second generation TKI first line, then lorlatinib comes automatically.
Then, yes, sir.
Okay. So this patient was started on ceritinib. It progressed over the 7 months. Now, Dr. Sameer, what would be your management? Again NGS, again a tissue biopsy, the same story repeats itself?
Yeah. So basically now the chances of having a compound mutations is also increased, as one of the slides showed that. So the chances of responding to, patient may respond to lorlatinib if there is no compound mutation. So I will again like to get the NGS testing, and maybe there is off-target mutations are also there.
We'll come down to the compound in a minute. We'll come to compound in a minute. You have picked up that thing. I think the next slide will have that. But I want to ask a very specific question to my panel here. And Kshitish first and then Bharat. Now let's say you have a patient on ceritinib progressed. You have a mutation which is detected on the NGS versus no mutation. Does your treatment differ here? Like if there's no mutation, you would prefer a chemotherapy. If there's a mutation, you would prefer lorlatinib, or you still go for lorlatinib, but you tell the patient because you don't have a mutation, your chances of having a longer response or PFS is little lesser. So am I clear on the question which I'm putting forward? Shitesh.
Yeah, what I understand is that whether we have a second option, if you see a targeted therapy, we have only one option of lorlatinib.
Yes.
And the mutation, suppose is there are compound mutation, and we know that the lorlatinib is not sensitive to this that
No,
thing.
let's see the compound part. On the third line lorlatinib, if you do NGS, if there is the patient comes back with the NGS report that there are mutations, registered mutations, or report comes up that no registered mutations are found, does it matter the way you choose the drug lorlatinib versus the chemotherapy?
Currently, sir, practically it is not actually I am choosing as per the guidelines as the third line. But
Okay.
now henceforward, depend on the future evidences about the sensitivity, about some specific, there is a common mutation like G12,
Okay.
20 mutations and all. I can choose a lorlatinib whenever there is a sensitive mutations are there, and
Okay.
versus a chemotherapy if it is not responding to that.
Okay. Bharat, your take on that in a quick minute, and then I'll show you one data set, and then I'll ask your opinion on that.
The thing is, mutations, till now in my practice, it has not mattered.
Okay.
Usually I would give the drug. Many of the times I may not even know which mutation, because I might have done just an IHC ALK and not proceeded further and started the ALK treatment. But now, like the EGFR story, within the next 6 months, mutations are going to matter, and your choice of drug based on mutations are definitely going to be the way forward in ALK, no doubt about it.
Okay, this is a data set which was there in 2019-20, and this has been talked about, not enforced upon a lot of us. It is not the final level of evidence. This is prior crizotinib if they give lorlatinib, and this has shown that if there is a tissue mutation for ALK, then the patient has a better PFS than if there is no mutation. And once you do it post second generation, look at the lower part of the curve. The blue line is those patients who have received lorlatinib post having a tumor ALK mutation positive, and the red line is those who do not have a mutation negative. It is not that if someone gives third line irrespective of mutation, he or she is wrong, but data set shows us that if someone has a mutation, and 2019 we were not specific about the type of mutation, those patients did much better with having lorlatinib as the third line than those patients who did not have a mutation. So the concept that goes that probably these patients who did not have a mutation for ALK had an alternative pathway which was not sensitive to ALK inhibition. That's why these patients did not do very good with the ALK inhibitors. Bharat, do you think now this will give us more of a confidence? But although to be very clear to this panel that you have the right and approval to give lorlatinib irrespective of the mutations. That's said and done. That I'm not arguing that point. What do you think of this data, Bharat?
As I said, we really have to now dissect out which are going to be the resistant mutation, which are going to, and decide on that. And that is the way it will go forward in the next 2 years.
I totally get that.
It would not be chemo for everybody, lorlatinib for everybody, or alectinib for everybody. It would be choices like we do with EGFR.
Okay. So till we come to compound, this part of it, I wanted to give them the message that third line lorlatinib is approved. If you have a second generation TK as the first line given, second line it is approved. If there's a mutation, as per the data, which is probably not the highest level of evidence as per that, but you do find the curves do separate on the PFS, and actually it is 11 versus 5 months. It's a gross difference actually. If you see the hazard is 0.47, it's not a small hazard. It's around 52%, 53% benefit. Number two, what is there? The concept that goes probably the red line, the mutations were negative, and it shows you that there could be alternative pathways, so ALKs could not respond, inhibitors would not respond, and that is what the concept was. But still now, then also you find significant responses with lorlatinib in the ALK mutation negative subset. That's the point which I wanted to type in. Now, compound versus single, with this elite panel of 4 panelists, first Kaushal, then Shitish, and then Sameer. Do you have experience of the compound versus single? Because if you are doing NGS routinely in a practice, then only you will be getting this. If none of us are doing NGS on progression, we would not be getting this. So Kaushal first and then Shitish.
Right, sir. If we are doing NGS, then we have a definite evidence which mutation is, either it is a single mutations or multiple mutations. And as per our experience, if we are using first generation, second generation,
No,
and then
do you
later
have
on,
experience, personal experience on this compound mutations?
sir, I have one patient who having
Okay.
such compound mutations on ALK positive patients, and that
Mhm.
mutation has been resistant with the first and second generation ALK inhibitors, and straightforward we use the lolatinib as a first line in that particular subset.
Okay. So, Sitish or Samir, experiences on the compound mutations, because this is there to stay now, and especially post lorlatinib. This is now going to come, especially post lorlatinib. The compound mutations are more there. It is shown to be around 30 to 40% actually. Sitish, any experiences personal, or Samir?
No, I don't have a experience of combined mutation at present because of
Okay.
the
Okay.
this thing. Usually we usually do not do and all these things. Now,
Yeah.
one more question. That is, sorry to interrupt.
Yeah.
Just want to ask a panel in the first future discussion of possibilities of using TKI plus chemotherapy in ALK. What are your opinion in
Okay.
that?
So I'll come to this question in the last thing. I'll remember this and put up to the panel this, just to complete the 2 or 3 slides more. These are the 3 mutations which are there as compound. So if I can, anyone of you wants to take this, because the 1196 is a gatekeeper mutation, and we are looking at this as a more resistant to crizotinib, and the other 2 would be resensitive to crizotinib. Anyone wants to have a comment on this, because this is how we are going to look at the compound mutations. Dr.
TP.
Samir or Dr. Bharat?
Dr. TP.
Yeah.
Yeah, Dr. Bharat Bhosle. Hi.
Yeah, please.
Good afternoon. So there was one patient I categorically remember. He, was ALK positive and started on crizotinib. Within 3 months, there was a progression. No symptomatic benefit. Even imaging was progressing. He was put on by my colleague on alectinib. No symptomatic relief. I was pursuing this patient, categorically to repeat the biopsy. In 6 months, he has finished therapy. Specifically, we did the foundation, and it was L1171M G1269A mutation, and which was resistant to lorlatinib, the foundation one, and it was sensitive to ceritinib and entrectinib, and sensitive to brigatinib and entrectinib. So some of the mutations, so some of the brigatinib and ceritinib sensitive.
Yeah.
So I would like to share this experience. So this patient was later on started on this one of these, and then started improving.
Yeah. So now my point is now
Sahoo,
we would not remember. Yeah, please. Anyone want someone want to come?
Vijay, yes, sir. Last 5 minutes left, sir.
Yeah. We will do that. We will finish off. So basically, what I mean to say is, I think offhand it will be very difficult for the panel to remember which is sensitive to what. It's more like we have to go back, look at the data. But basically, it points to that if there is a G1202R mutation, which is normally sensitive to lorla, but if you have the L1196M code existent there, it will be resistant, and these drugs are usually now sensitive to the newer so-called novel ALK inhibitors, which was told in the panel in the previous lectures. But the uniqueness of this was, if you look at the previous 2, if you have a compound mutation like C1156Y and 1198F and the 1171N and 1256E, they regain the sensitivity back for crizotinib. So this is the uniqueness, that crizotinib may be retried after failing in the first line post lorlatinib. If you have these compound mutations, the sensitivity of crizotinib comes back. This is one message which I really wanted to put forward. I'm going to skip this. Just one question to Dr. Samir. Where do you prefer chemotherapy? Now, after 3 lines, when lorlatinib has failed, would you prefer chemotherapy? Because I think this patient subset do respond very well to chemotherapy.
Yeah, they can be tried with along with immunotherapy also.
Okay.
And in fact, I have tried it because lorlatinib was not available, so I have tried it in immunotherapy with chemotherapy. Yeah.
Okay.
So
the message I also wanted to point out is,
but patient did not respond very well.
Okay, they do not respond. Your patient did not respond well. Okay.
They don't respond. Yeah.
So this patient on question took 3rd line lorlatinib, progressed in 9 months. NGS here showed C1156Y, which was previously there, but now had L1198F, which was the sensitive mutation crizotinib. So this patient actually was put back on crizotinib, and after the patient was put back on crizotinib, you do find the patient who was in hepatic failure. This is a publication in EGM. The response happened. So what I wanted to make with this case is, you might also get a chance to retry the first generation TKI, that's Crizo, but you have to look out the mutations combination, the compound ones. And sometimes the compound mutations like G1202R and the L1196M, if they come, they are not sensitive to either LORLA or Crizo. Then probably the newer novel ALK inhibitors will respond. Or second thing, what I want to say is you would probably get a chance of getting chemotherapy here. Last thing, if you have a MET amplification, Dr. Bharat, post first line of ALK inhibitor, would you do combination of ALK and MET or would you do just ALK?
I think I would, MET along with ALK, I would maybe prefer chemotherapy.
Okay. Dr. Kaushal and Dr. Satish.
So I would go with the combination ALK as well as MET inhibitors.
Okay. Satish?
Yeah, these both options are okay, but what I was discussing, whether can we use a chemo plus TKI?
Chemo with the TKI. I think if Kumar Pravas is there in this, he's around. So can you tell us? Because I'm not sure there is a data on this part of it, like we are talking of a TKI, EGFR and a chemotherapy part. So you're putting analog to that. So if Kumar Boss is there, if he can come in and just speak on this, because I don't have first idea, or anyone in the panel has some idea about this question, Satish, TKI and...
Dr. Vanita is there. I'll give it to Dr. Vanita for her.
Vanita is there? Yeah, Vanita, please. Your thoughts on this. Vanita?
Sorry. Hi. Sorry.
Vanita, are you there?
Yes, I'm here, Sahoo. Sorry.
Yeah, you got the question. What is the asking that can we at the progression use a ALK inhibitor and a chemotherapy?
Yes. So that is a very intriguing thought, and there is some small data. We had actually planned a study of that, so crizotinib plus chemotherapy for patients who can't, who are unable to afford. So this was not your specific question, not with a different mutation, but patients who could not afford lorlatinib or second generation ALK inhibitors. Okay. We haven't completed the study yet, so I can't give you that data. But yes, it is it's a very exciting option for sure.
But at this point on a trial setting, that's what you want to see.
Yes.
And for this question, would you do a combination of a ALK and a MET inhibitor?
So I guess officially, it's difficult. You would not get data for each and every one of these combinations of mutations. But this is the discussion that we have probably in our molecular tumor board every time, because as we are doing more and more comprehensive profiling, we find more and more combinations of mutations, and rationally this should be the way to go to to target both the mutations. So there was a lecture that I had heard from Dr. Razel Kurzok, and her opinion is that all of these should be targeted, and perhaps by lowering the doses of both of them. So what she does is she gives half dose together.
Yeah. The crizotinib, the one of the ALK is given at a half dose. Yeah. Okay.
Dr. Sahoo, what would be your choice in this situation?
Combination. The data, how much ever I've read, is the combination. As Vanita rightly pointed out, if you look at the case reports, most of them tilt towards the combination. Here I just put this up because if you look at it, there was 2 case studies again. And one they used crizotinib because crizotinib has a MET inhibition also. But they did not prefer it much because crizotinib, because it was ALK and it was third line. Some of the mutations had been developed which was resistant to crizotinib due to ALK. That's why crizotinib was not a very beneficial thing. But otherwise, the combination looks to be the more appropriate option. But nothing is, the last word has not been told like Dr. Vanita told. But my thinking is that if you look at this and the BRAF one, there's only few case reports. And again, it was that if you give a single agent BRAF inhibitor, it does not help. If you give an ALK and a BRAF inhibitor, at least in the preclinical data, it looks very impressive. So I think these are exciting days. I think the way people are moving forward is a combination. Vanita, is it true? That is the take-home message should be at this point. No one knows the right answer, but we are moving towards probably combination. And if the data is out in the larger data set, we would be using that way.
Yes, absolutely. Personalized medicine, soon to come.
Yeah. But why not chemotherapy, Sahoo? I mean, they are chemosensitive tumors. Instead of combining, in second line, third line, subsequent lines, at some point of time, these patients are going to take chemotherapy. And you need not push off chemotherapy so long that the patient does not even tolerate chemotherapy at that point.
Yes. At this point, the consensus is if you fail 2 or 3 lines of ALK inhibitors, probably all of us give chemo. That's what the consensus is. But this data set as they evolve, and if you have a target, Bharat, now tell me, would you not hit the target or would you go with the chemo? Now you tell me.
The problem is with both compound mutations and mutations that are in two different domains. We assume that by giving two targets we are achieving something. Our NGS is not good enough to have picked up everything. We may not be really serving the purpose of getting a good response rate. And many times in second line and third line, we need a quick response rate for the patient to be stable. So, I would just, second line and third line for ALK or even the other mutations, I sort of tend to go towards chemotherapy quickly.
The consensus at this point is beyond 2 lines, but I think Bharat has a point here. If you want a quick response, you could go for chemo. It's nothing stops us from doing that. But yes, if you have a target, most of us would like to hit the target. That's what it is. And you have drugs like the gilteritinib and the TPX0131, which was shown, especially TPX0131 was sensitive and responded to the compound mutation which was resistant to all ALK inhibitors. So I think this is exciting days. So with this, I really end my panel because time is already out. So the conclusion is repeat biopsy can provide critical information. That's what I wanted to drive as to whether sequential therapy with a different inhibitor may be effective. And the most important what I feel has been that you should do a broad panel rather than a targeted amplicon type of NGS, because you would be missing out, especially post the second gen TKI, on the other mechanisms like the MET, BRAF, EGFR, which are resistant pathways. The serial repeat biopsy can not only provide clinical relevant insights, but also can offer an invaluable glimpse into the longitudinal evolution of cancer. So this is the field which is very fluid, is very dynamic, and I think things are going to change fast. But I think most of us are going towards the NGS, followed by a NGS and followed by NGS, and we want to have a target and we want to hit the target, and that is how the field is evolving. And ALK, every time you give a drug in a stage 4 ALK inhibitor, it is going to develop resistance. So that's why NGS is going to come in big time into this subset of patients. I thank the panel. I could not discuss something which I wanted to because of the lack of time, but thank you the organizers, thank you panel, thank you Vanita for volunteering, thank you Bharat for that question, and that's where I end. Thank you.
Yeah, thank you, Dr. Sahoo. As usual, a very dynamic moderation and bringing out some burning points. Any final words from Dr. Jacob George, sir?
The participants kept their time, certainly. The panel was very dynamic, and it's just a matter of more and more data, more and more technology improving our cancer treatment. That's how it is, and that's the future. Thank you.
Sir, Samir here. One question, sir, only one question. Sir, just one question. If a patient progress only in brain and there is no systemic progression, in such cases we don't get tissue biopsy. So in a brain only progression, so would you like to do liquid biopsy to see for the mutation?
The point, Samir, here is that the NGS does not pick up is not very great on the blood NGS for the CNS thing. There are data on the CSF. The data is there. We do have some data on the CSF, but the pickup rate on a blood NGS for the CNS only disease, the new mutation would be very, very difficult. That's a limitation. But I don't think that stops us from doing a liquid NGS. That's my take. If Vanita is around, she can add something more.
So, but parenchymal meds CSF would be helpful or only for leptomeningeal meds?
Yeah, it is good for leptomeningeal. I totally take your point, and the point is that you do not have anything else than a liquid NGS here. That's also a point that has to be highlighted. You would not go for a stereotactic biopsy to ask for tissue for NGS. That's also there. So I think that's the best you can do is to ask for a liquid biopsy. That's my thinking. If anyone who does more of this can answer, Vanita, Kumar, they can pitch in.
Yeah, I think we don't have any further comments. Thank you everybody for joining these sessions, interactive sessions. Now I request everybody to join us for lunch and be here by sharp